So today we are dealing with the topic embryonic mishaps. I'll be sharing this with you. So mishaps are painful when they happen, but years later, a collection of mistakes is what is called an experience. So embryonic mishaps. So these are the introduction. Now coming to the definition. Mishap is that can be unfortunate occurrence that happens during a treatment. Some owing to inattention to details, others totally unpredictable. Now coming to the classification, there are different classification based upon the cleaning and shaping, based upon the accidents during duration, accident during post-phase preparation. According to Engel, the mishaps are access related, instrument related, obturation related, as well as miscellaneous. Access related mistakes are treating the wrong tooth, missed canals, damage to existing restoration, access cavity perforation, and crown fracture. Instrument related is ledge formation, cervical canal perforation, midroot perforation, apical perforation, separated instrument and foreign object, canal blockage. Now coming to obturation related, it can be over or under extended root canal filling, nerve paresthesia, vertical root fracture. Miscellaneous are post-phase perforation, irrigant related, tissue emphysema, instrument activation, and injection. Now, according to Leaf Frozen, there can be incomplete anesthesia, access cavity, perforation from pulp chamber, root perforation. These are the clinical endodontics, and root perforation can be apical perforation, lateral perforation, post-phase perforation. Obliterated root canal, fracture of an instrument, adverse reaction to medicaments. So, the main adverse reaction to medicaments can be rooted tissue irritation, neurotoxic irritation, allergic reaction, overfilling of the root canal, vertical root fracture. Now, how do you manage a mishap? First, you have to do is recognize the mishap. Second, you have to correct it. Third, you have to reevaluate the prognosis of the tooth. So, access-related mishap is the first classification. Treating the wrong thing. So, how do you know you have treated the wrong tooth? First you have to recognize it. Either the symptom of the patient continues, and secondly, after the rubber is removed, you'll be recognized. Okay, you have done a mishap. What are the main cause of mishap? It can be inattention. You are not attended or you are not aware of the proper tooth, and it can be misdiagnosis. And how do you correct it? The correction can be the appropriate treatment of the main tooth. The first tooth you have done the mishap and the actual tooth. Now, how do you prevent it? Obtaining as much information as possible and marking the tooth to be treated with a pen before isolating. So as in, you can see in the video graph, the tooth is marked with a pen. So this way you can prevent the actual mishap. Okay. Now come to missed canal. So what are the causes of missed canal? Some root canal are not easily accessible or readily apparent. So, and that can be the anatomical causes because sometimes the tooth anatomy is different. Second is dentist related. Like if you are lacking the knowledge about the root canal anatomy, okay, there can be a mishap. Another is a failure to adequate search for these additional canal. If you're failure, example mostly is the nasal root of maxillary molars as well as the distal root of mandibular molar. If you are failure in knowing the anatomy of the tooth, that's the chances of the missed canal. Yes, next to the recognition. How do you recognize it? During the treatment. An instrument or filling material other than exactly centered in the root canal is present. Then there is the high resolution magnification. You can use a magnifying loupe or a microscope or endoscope to recognize the missed canal. How do you correct it? First and foremost thing you can do is the retreatment. Next is the prognosis. Yes, you have done a miscap, then there is a chance of decrease in the prognosis. Now, how do you prevent it? Actually, the significant percentage of failure are related to the mixed canals. So, how do you prevent? In maxillary central incisor, you should know the common variants. Like in maxillary central incisor, there's a chance of extra canal. In maxillary first bicuspid, sorry, maybe the three-rooted have MBDB and palatal canal. Maxillary second bicuspid. So, you have to know all these common variations. Now, coming to, you should know the law of orifice open. First is the law of centrality. Second is the law of concentricity. Third is the law of CEG, law of color change, and the law of orifice location 1, 2, and 3. So what is law of centrality? Floor of the pulp chamber is always located in the center of the plate at the level of the CEG. That is the law of centrality. Now, law of concentricity. The wall of the pulp chamber are always concentric to the external surface of the tooth at the level of PEG. Law of PEG. PEG is the most consistent, repeatable landmark for locating the position of the pulp chamber. Law of color change. So, as you are reaching the pulp chamber, you can see the walls are darker in color. Now, the law of orifice location. The orifice is always located always at the junction of the wall of the floor or the angles in the floor wall junction or at the terminus of the developed fusion lines. So as you can see, the axis cavity and the radiograph. So you should know the anatomy of the tooth very well. Next, using a magnification loop, microscope, you can even use diabetes and ultrasonic as sodium hypochlorite. You should know the Chamberlain blood test. Sodium hypochlorite can aid in the diagnosis of missed or hidden canal by the means of the effectiveness test. Okay. And then third is the white line test. That is the toughening methods. Okay. So these are the methods you can use. Now you can even use micro-openers and micro-debriders. Damages to an existing restoration is a third mishap. So how do you correct it? Bonding composite into the tape. How do you prevent this mishap? Avoid placing the clamp directly on the margin. And ideally, you can remove permanently cemented ground before you starting the treatment. Okay. Now, other methods are the equivalent chisel should be held firmly in the hand with the forefinger placed beyond the wound. So these are the methods to remove the crown. Access cavity perforation is the wood mishap. So undesirable communication between the pulp space and the external tooth surface, access or BMP or post-space perforation and crown perforation. Crown perforation you can make either laterally or perforation. You have to make sure that. Then what is the case? How do you, what is the main reason for the access cavity perforation? It's a failure to identify the angle of the crown to the root and the angle of the teeth in the dental arch, usually maxillary and lateral incises and mandibular first premolar. Okay. Now, using a surgical length burr, either you are inadequate access prepared and misidentification of the canal. These are the main causes of the perforation. Recognition. How do you recognize it? You can see an immediate bleeding, pain of patient, leakage, apex locators, to the apex locators, radiographs, and paper point. So these are the main method you can recognize they have made a perforation. There'll be sudden bleeding, pain, leakage, apex locator, radiograph, paper points. Now, how do you correct it? You can correct it with either using an amalgam, calcium hydroxide paste, triple EDA, GIC, Retapacha, tricalcium phosphate, IRM, plaster of Paris with various other material, MTS. So these are the common material used to correct the perforation. Prognosis. Actually, prognosis depends upon the location of the tooth, length of the tongue, adequacy of the seal, main canal, depend whether it's a main canal or natural canal's size. So how do you prevent it? Proper burr alignment with the long axis of the tooth. You should align the burr with the long axis of the tooth. Burr penetration of both the depth and angulation can be confirmed with radiograph. So if you are having any doubt, make sure you're taking radiograph and confirm it. Now, crown fracture. So treatments, you can use a circumferential band or temporary crown or chisel type fracture. Extraction is the treatment. If the fracture is vertical, you can go for extraction. Prognosis, it's less favorable. And prevention, you have to reduce the occlusion. Even after doing access surgery, try to reduce the occlusion of the tooth. And bands and temporary crowns can also be applied. So these way you can prevent the crown fracture. Now, instrumentation related mishaps. First is ledge formation, an artificially created irregularity on the surface of the root canal wall that prevent the placement of the instrument to the apex on an otherwise patent canal. A deviation of the original canal curvature without communication with the periodontal ligament, resulting in a procedural error, is termed as a ledge or ledging. Now, what are the causes? First is an inadequate axis. Second, large instruments out of sequence. Third, straight or inflexible or too large instruments in curved canal. Insertion of the instrument short of working length, unsuspected aberration in the canal anatomy, incorrect assessment of the root canal direction, forcing and driving the instruments into the canal, complete loss of control of the instrument if the embryonic treatment is attempted via proximal surface cavity or through a proximal respiration. Rotating of the file of the working leg, inadequate irrigation, overlining or chelating agent, attempting to retrieve broken instrument, removing filling material during embryonic retreatment, attempt to prepare calcified root canal, inadequately packed therapy. So these are the common causes of ledge. Now, how do you recognize it? Instrument may not be inserted to the working leg. Suddenly, fire no longer negotiate at all, but catches on a dead end. Loss of normal tactile sensation of the bone binding. Instruments point fitting against a solid wall, radiograph with the instrument includes. How do you correct it? You have to locate the ledge. You have to irrigate it. Shorter instrument is preferred. Number 10 or 15 wishing curve with the tip pointed towards a wall opposite the ledge. Tear-shaped silicate instrument stops. So recommendation, once it can be placed apical to the ledge, short file stop with the instruments. When the file is moved freely, slightly longer pull, the file slide easily, turn the clockwise, pitch for the file, check repeatedly, curve is maintained. Recommendation, greater type of file can also be used to reduce extent of the ledge by using the minimum number of files. Now, what are the alternate treatment procedure you can go for retrograde, amalgam surgery, resection or radicectomy, intentional replantation, or extraction. You have to know how to prevent it. Accurate examination of the diagnostic radiograph, awareness of canal morphology, frequent recapitulation and irrigation, patches step back and balance view technique, pre-curving the instrument and not forcing down, using the instruments with non-cutting tip and using nickel titanium files. Instrument modification, you can use flexor files, safety edge files, flexo file, both and medium. Okay, these are the safe-sided files. Now, radicular perforation and the rest will lead to the next class. Okay, thank you.